Hello, and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined by my co-host, Josh Davis.
Yeah, hi, my name is Josh Davis, as Angela just said. I'm also an infectious diseases physician, and I'm based in Newcastle in Australia. It's about 2 hours north of Sydney, and also one of the other editors of CMI Communications.
So we're here today to talk about phage therapy. We're delighted to have two world-renowned phage experts with us, a microbiologist-clinician duo whose experience with phages goes from bench to bedside. Dr. Shawna McCallin is a microbiologist who trained at the University of Pittsburgh, where she got an early introduction to phages, and later at the University of Lausanne here in Switzerland for microbiology and University of Geneva for clinical trial management. She also briefly worked at Nestle Research Center, where they had an active phage research program.
I'm really happy to be here. Thanks for the invitation for us to discuss a little bit about what we've been doing with phage and phage therapy.
And Dr. Lorenz Leitner is an assistant professor and senior urologist working together with Shawna at Balgrist University Hospital in the Department of Neurourology in Zurich. And that's a new one to me. I've never heard of a department of neurourology. People often get urology and neurology mixed up. So it's cool to have a department where they're together. Lawrence and Shawna lead the group for phage therapy and research as a clinician microbiologist duo, which is a perfect combo for phage therapy research. And their research centers around the urinary tract, both infections and the microbiome.
No, thank you for the kind introduction. So I'm also looking forward for a great podcast and to give you some insights in Shauna's my everyday life.
Okay, so we're going to try and start each episode of Communicable from now on with a get to know you kind of question for our guests and also our hosts. So today I'm going to ask, what is your favorite infectious diseases themed novel or movie and why? And if you can't think of a novel, you can do a movie. Just by way of example, I'll start with mine. And mine is The Stand by Stephen King. So you can see from that example, The Stand's not really about infectious diseases as such. For those who are not familiar with it, it's about a highly pathogenic virus that's released by mistake from a secret US government research facility that then wipes out the majority of people on Earth. And really, most of the novel is after that. It's about what does humanity do? How do they recover with the total societal breakdown? So I like it because one other connection, I guess, is clinical infectious diseases is about people more than organisms. It's about understanding our patients, and it's about understanding human nature. And that's what The Stand is about. And how about you, Angela?
Josh, I just have to respond to you first because I think that's a really nice choice. I don't know the book. I haven't read the book, but now I think I will. I take it that is one of his non-thriller books because he writes beautiful short stories that are not scary at all.
No, that's right. It's not a thriller. It's not really a horror, although it has supernatural themes, good and evil and all that woven through it. It's one of the earliest novels he wrote, in fact.
Huh, okay, no, that's really good. I'm going to look for it. I agree. I think like a lot of us in infectious diseases are very much involved in it because it's, yes, about the microbes, but it's also very much about the humans, which I think we'll be discussing today. So my favorite book, so I knew this question was coming. I didn't know we were going to have the option for a favorite movie. So I scoured my brain for my favorite book and I couldn't really come up with anything like truly ID themed that wouldn't have been maybe a little cliche. Like I was thinking of like The Plague by Camus, but I read that 20 years ago and I don't really remember the details, so that wouldn't be very authentic. So what I was thinking of was actually a short story that is very ID adjacent. It's not really ID themed, but it's by Alice Munro, who died last week. So I think it was important to me to work her in here because she really was a master. And she wrote a short story called Some Women, which I think she wrote it in the 1990s or the early 2000s, but it took place in a much earlier time in Canada. And it was about a young man, a returning veteran from the Second World War, who was at the top of his game and then got diagnosed with AML, with leukemia. And so as he's slowly dying and being picked off by infections, these two women You're nodding, Josh, as if you know the story. Do you know it?
No, I've heard of it. I'm just nodding, thinking, wait, where's the infectious diseases in this? But you've said it now.
Like I said, very idea adjacent. But anyway, it's very much about humans, right? So coming back to microbes versus humans, it's really a lot about humans. And, maybe we're all just big microbes anyway. So anyway, it's about these two women who in this time period, it's in the 1940s, 50s, they sort of are fighting over this dying man. It's this crazy, you only figure it out later, what these women are doing to each other for this, essentially this horrible, it's very clear he's going to die. There was no therapy back then for leukemia. So he gets picked off by infectious diseases, let's just say. But I think it's a fascinating read for anybody who wants to pick up Alice Munro, knowing that she has just passed and recently won the Nobel Prize for Literature.
I'll definitely put that on my list. And Shawna, how about you?
I also had to sort of scour my brain. I have to admit, I haven't been doing a lot of fictional reading the last 10, 20 years. So I'm going to go with a movie. And the movie I first thought of was The Painted Veil. This stars Naomi Watts and Edward Norton and is about a cholera outbreak. And cholera has always been, I would say, one of the things that fascinates me most about infectious disease. It's obviously not something that we deal with here in Switzerland, but I've got a bit of a personal relationship to it because my dad got cholera in the 1970s before I was born. And he was in Afghanistan and got cholera and had to be evacuated back to Germany. So a really life-threatening issue for him. But then in the movie, it also demonstrates just the dedication that the clinicians and the nurses had to have to help people with this disease and the risks that they put themselves at. Of course, there's history with phage therapy and cholera, so it always made me think, but phages could have saved them. So I think there is a bit of watching it and this sort of personal relationship, but also then the motivation that it inspired me to be able to come up with, hopefully, I don't study phages and cholera, but there has been historical uses of phages for cholera. And also now there is a startup company called Phage Pro that looks at developing phages for the treatment of cholera. So I guess it all loops back to phages for me. You'll find this has been a lifelong passion. That's why I really liked the movie.
Great, and nice to bring it back to the phage theme too. Lorenz, finally, how about you?
Yeah, really good question. And I also had to think, is there actually a specific book I have read about infectious diseases? So maybe I just give insights on the last book I did read. It was 2 weeks ago when I was on holiday. I did read a wonderful novel by Daniel Kehlmann. He is a young, or not so young anymore, German writer and very talented. And he writes these historic books where he tries also to get historic insights and proper explanation of the situation. And this is a book called Till. It is about Till Eulenspiegel, who is a famous folkloric character in Germany. He was a court jester and made all these kind of tricks, and it plays through the 30 Years' War. And I remember a lot of scenes in that book where he did ride when he was at the court, and there was the pledge, I think this is the pronunciation in English, with all the people and the smell, how it was when the people were rotten in the streets, and he had to go forward and backward through one city to the other and try to get away from the plague. When you were reading it, you were really feeling being in these dark ages and how much more difficult it must have been back these days than today, and how much influence such infectious diseases had on society and also on Europe, on our history, and on the war. So this may be my experience I can share on books about infectious diseases.
Just a note on that, the plague is caused or was caused by Yersinia pestis, and there's also phages for that.
Of course. And thank you, Lorenz, and that's a nice feed in, Angela, to start our discussion about phages.
Thank you very much, Josh. So Shawna, can you remind us what a phage is and how it works?
Sure. Phages are essentially viruses that are specific for bacteria. So in a lot of ways, they operate as any virus that we can think of, but they are the ones that we tend to study the most, and the ones that are primarily used for therapy are called caudovirals. So these are phages that are tailed phages. They are predominantly using double-stranded DNA, and they have sort of this icosahedral head structure, and then different lengths of tails, and then tail fibers. And the tail fibers are really what mediates the specificity for the surface of bacteria and the receptors that are located there. Phages are also everywhere. They're the most ubiquitous entity on our planet, actually, and these estimates range up to 10 to the power of 31 phage particles on the planet. And so this means that we've all been exposed to them before. You know, if you've ever gotten a mouthful of seawater, there was probably several millions of phages in there. And they really are something that we don't realize just how far they are. You know, they're in the water sources, in the soil. They're also part of our intestinal flora in some cases, as we'll discuss more about. They can be used then to harness this bacteriolytic activity that they have to treat infectious diseases.
Shawna, I've heard, do you reckon this is true, that phages are the most abundant organism in the known universe if you count the number of them?
Correct.
Wow, that's amazing. So, Lorenz, can you give us a brief summary, if you can, of the history of phages? When were they discovered by humans, and when did we start using them, and what happened after that?
Yeah, absolutely. So phages have been discovered more than 1 century ago in the early 20th century by Frederick Tward and Felix Terrell. And they actually had quite some success after they were found, and they were used to treat infectious diseases. However, with the discovery of penicillin by Fleming in the early 30s, or during the 30s, they were used less and less because penicillin and thereafter antibiotics were much easier to use than phages. Because what we learned from Shawna is that phages are super specific. So for every single bacteria, you have a specific phage, and they will not go on other bacteria. So this was probably one main reason that phage therapy was not followed anymore, because antibiotics were just much easier to use, and antibiotics are, as we all know, fantastic drugs. Phages actually do work, and phage are highly effective, but with antibiotics, which can be produced standardized, etc., it was much easier to go for that.
I think what's really interesting about the history of phage therapies, you know, Lorenz just explained that they were discovered before antibiotics. And they were actually used for the first time in a patient in 1919, a pediatric patient suffering from Shigella dysentery. And so the stage of microbiology at that time point, you know, they weren't even sure what they were dealing with, but they were able to isolate the phages and provide them orally to this patient with a really clear treatment effect. And I think Lorenz really hit the nail on the head when he said that it just came about that when antibiotics were discovered, they have a much broader spectrum. And so this is really, I think, what shifted the balance. But then in Eastern Europe, so the former Soviet Union continued with phage therapy. And that's why we see this existence of phage therapy in those countries today compared to the Western countries, where we really went full speed ahead with antibiotics and let phages fall to the wayside.
So, Shawna, that brings me to another question that we had for you. What is the availability right now of individualized phage therapy versus phage cocktail in Eastern Europe, over here in the West, and in places where they're using cocktails like in Eastern Europe? What is the extent of resistance to phages?
So this is going to be probably a long answer, but funnily enough, I just got back from Tbilisi, which is sort of the central point, I would say, for phage therapy in the world. So the Eliava Institute for Bacteriophages and Bacteriophage Research is located in Tbilisi, Georgia. And this was originally founded in 1923. So it's also a very historical place, and just really amazing place to visit in general. So they're still doing phage therapy there. They have a patient clinic, a pharmacy, and a company that does production and distribution. So in terms of, I would say, more Eastern Europe, then there are companies that are producing phage therapy. They're often sold as over-the-counter solutions. So I bought quite a few myself when I was there. You can just go to the pharmacy. They have different cocktails that are available for different indications. So that's what they're more formed around. Is it for an intestinal indication or for a skin indication? And they also now, since the last time I was there, sell formulations. So you can buy a cocktail as a cream or as a suppository.
So, like, what kind of organisms are in these cocktails? What are the targets in these cocktails? Do you get, like, for the intestinal, are you getting, a bunch of enterobacterals? What's happening?
The cocktails, they have, I would say, different spectrums. Most of them cover about 5 to 6 different species. So using the intestinal one as an example, it's Shigella, E. coli. I think they also have Pseudomonas. They include Staph aureus still in those products, Streptococcus. And I'd have to double check. I think there's also some Proteus phages in there. But the one that they don't have, and I was discussing this a lot with them, as part of their phage cocktails are Klebsiella phages.
Oh,
So
interesting.
aside from these pre-formulated cocktails, the Eliava Phage Therapy Treatment Center also offers an individualized service. So say you have a pathogen that isn't sensitive to the cocktails or isn't covered by them, they can also go into their very large collection and then look for what they call autophages that are specific to that bacterial strain.
So, Sean, I'm really interested in the over-the-counter phage preparations you were talking about. Like, how much do they cost, for example?
Oh, this was in Georgian currency. Lawrence, do you remember the conversion? Because we've also bought them and
Yeah.
paid that way, but they're not that
I
expensive. They're
sometimes
between
order them to Switzerland, and they have a very nice service where you can actually order them. And I think about 5 vials, it's about 20 Swiss francs. So it's about also around 20 US dollars. So probably they're much cheaper when you buy them in Georgia directly. So they're rather cheap.
Eliava has their own pharmacy, but then if you go to some other ones, there's another company that also provides these cocktails.
Lorenz, you're saying you buy them online. Is it in your role, the Balgrist
I
Hospital, or can anybody just buy them online?
I don't buy them online. I was also in Eliava before, and I have contacts with the pharmacist from the Eliava pharmacy, and I always get it directly via her. So I have not the experience with getting them really online. I think they have such a service, but I'm always directly in contact with my contact from the pharmacy, so I cannot consult on that.
So they're not like on Amazon.com or something.
Not yet.
And what about the resistance issue, Shawna, that Angela mentioned?
The resistance issue is an interesting one because it'll probably come up in some later topics we'll discuss. But what they do there is they periodically will update the composition of the phage cocktails. And this is done based off of epidemiological strains. And so one of the paradigms that really clashes with our standard view of drug development is that phage cocktails and phage products need to change. They need to adapt with changing epidemiology. Once they notice that there is an issue with resistance, then they kind of update their cocktail composition and modify it accordingly.
So it's pretty much not comparable at all to antibiotic resistance. Is that what you say, Shawna?
Yeah, I would say it's difficult to provide estimates. For example, the resistance rate towards the products using Georgian strains is probably lower than, say, if we would test our isolates, because phages tend to, they're designed off of the strain panel that is used to create them. So in Georgia, it's used off of Georgian epidemiology. So whatever strains they're getting in, I can't give a percentage of how many strains their cocktails target. There's a difference between sensitivity or susceptibility. So this, like, does a phage and a bacteria work, versus resistance. Resistance is something that then develops. So I think those are two different things. There's one question of like the coverage, and then there's the second question of, well, how much does resistance develop throughout a treatment?
And how are they picking this up? I mean, are they doing regular point prevalence studies? Maybe not published, but are they internally, how are they knowing when to change, when to update the cocktails?
You bring up an interesting question that, I can't answer from their perspective, but what I can say is this is a tradition that's been going on 100 years. And I think that's one of the main issues we have in understanding their processes, because they're just used to doing things in a certain way. So they have their own firsthand knowledge, empirical knowledge. about when this is required and how they do it, but I can't answer exactly, is it a certain number of strains or how frequently do they do it?
Yeah, they also don't talk about it. They don't say how they do it because when I was doing their trial, I specifically asked these questions to several people of the institute, and they don't share or don't disclose this information. So this is
Yeah.
maybe what we will call their intellectual property.
Interesting. Yeah. So that kind of brings me to the next question, which is for both of you. Can you take us through the process and the entire process, bringing phage therapy to a patient from the bench to that patient at the bedside? What are all the steps and how many actors are involved in this?
That's a very good question. Can be a very long question or a very short question. Maybe I start, Shawna. Is that good for you? Because mostly it starts in clinics. I see a lot of patients with recurrent UTIs or with UTIs in general with multi-resistant infections. And I also get a lot of emails from patients all around the world who want to be treated with phage therapy. I mainly focus on UTIs because I'm a urologist. When I have a patient and I think this is a potentially good candidate for phage therapy, or this is a candidate we should consider further, the first thing I do is I go to Shawna and tell her I have this patient. These are the landmarks. These are the infections we had before. These were the strains we had before. And I discuss it with her to ask her opinion if she thinks this is really also from the microbiological view, a potential patient. And the special things we consider is it always the same pathogen or is it always a different pathogen? Is it a monomicrobial infection or is it a polymicrobial infection? These are the things we discussed. And when we figure out this is a potential candidate, then the process starts. And from my side, I inform the patient and I have the patient tell me every time this patient has a new urinary tract infections, because what we need to do is we need to collect bacteria from these patients to know, do these bacteria are these bacteria sensitive to our phages?
And that's when it kind of comes to me, right? So biggest change I've seen in the world of phage therapy is the interest of clinicians. Because I think as a microbiologist, we don't treat patients. And so that's one of the reasons I really appreciate working with Lorenz, is because he's the interface with the patients. He's the one who sees the need. And this is what I've really noticed, I would say the last at least 5, maybe 7 years, is that the clinicians are then coming to the microbiologist saying, can I have phages? And that's been a big interest, because then what I say is, well, possibly, but then get me the strains. This is the big thing that we then check afterwards as well. What type of activity do our phages have against the patient strains? And if it's sufficient activity in vitro, there's a couple of ways of measuring this, and groups, I think, decide what is sufficient activity a little bit differently. There's a lack of standardization in the field that we're all working collectively to try to address. But if we say, okay, there's some activity, then what I'll end up doing is producing the phages. In an ideal world, we would also have a pharmacy that I would pick them up from. But then we have a well-documented process in the lab that we produce the phages with.
Can I just interrupt you there, Shawna, for a couple of clarifications? So firstly, Lorenz has given you, say, an E. coli strain, and you said you screen it against a number of phages that you have. Where did you get them from? And do you go and find more, like you have a library or something? And then the second thing, while I've interrupted, is you said I then produce the phages. Can you just tell us how you do that and what that means?
We have an in-house collection. So these are anything that was isolated from the environment, primarily wastewater or hospital water samples. These are really good sources for phages. We've also worked with other academics to use their phages, so we can use a copy of their collection and include them in our sensitivity testing. It's really nice to have a network, because we're not a fundamental research group, so we do some isolation, but then working with other groups that have these large collections has been really helpful to identify active phages. And then when it comes to production, what I want to mention is, Lorenz and I are able to do a limited number of these treatments. This is not like a registered therapy. The way that we produce phages for these individual patients is very different than what you would do for a standardized therapy or for a clinical trial even. We do it in a very small scale for these specific patients, and we use what we know in the lab. So we do an amplification step, and then a concentration and a purification. Now, our purification method is ultracentrifugation through a cesium chloride density gradient. That sounds way fancier than it probably is, but it's a good way of cleaning up the phages. So removing any of these residual bacterial proteins or LPS components that are present in a phage lysate. And I would say the emphasis on this is that we then send our final phage, I don't want to call it a product, but our phage solution, we send that for external quality control. And that's really what we base our treatment off of, is that, do our phages pass quality control with an external validated provider? And then we feel really confident that these, for a very small amount of patients that are exhibiting treatment failure, could be used.
And how long does that take, Shawna, to send it out for external quality control?
It depends on the urgency of the case. So a lot of times, especially with urinary tract infections, it's not urgent. The fastest we could probably do it is have the phages ready in about 7 to 10 days to send for quality control. And then it depends on the tests that you use. I would say a minimum of 2 weeks for quality control.
So this comes back to, we were talking before about the pros and cons of phage cocktails versus these tailor-made ones, right? And the phage cocktails you could use off the shelf in theory, and the tailor-made ones take 7 to 10 days. In my experience, is very quick, because we've done this a bit in Australia. It's taken weeks and weeks for us to get a tailor-made phage on the few times I've done it. So why not?
Could I ask what species?
Klebsiella, a couple of times, and one was for an atypical mycobacteria, a MAC.
That's why. So
And why is that?
Well, because when I say the fastest, I mean, I'm assuming everything goes well, that we have active phages. For example, making phage against E. coli is relatively straightforward, but we've also been working on a Klebsiella case because Lorenz has Klebsiella patients. And I told him we don't.
I'm sure you do.
Yes.
Yeah.
And this is much more difficult, first, in finding an active phage because the phages are more specific. And secondly, to clean the preparations is also a lot more difficult because the presence of capsule, and then this really creates an issue for the purification process.
Yeah, wow, that's cool to know all these hidden details that most people wouldn't think of, right?
Yeah, I was actually going to ask you, Shawna and Lorenz, what bacterium, if there is one, what is the easiest target for phage therapy? What's the
Shawna,
bacterium
don't
that's
say
like a slam
staph.
dunk? Huh?
Lorenz knows what I'm going to say. I think it's largely based off of what experience people have had. I mean, from a phage perspective, Staphylococcus aureus is the easiest because there's a broad spectrum phage, and then you don't have the issues of purification and LPS contamination. So this is why I would say staph is good, but then you have additional problems about activity in serum, and so it really depends on both the target bacteria, but also the indication. What I would say is, in a dream world, it would be a Staphylococcus aureus monomicrobial wound infection. That would be like my dream
With topical,
scenario. Yes.
Yeah, with topical application where you
Maybe
can
not
just
wound, maybe joint, because it would be closed and it would not be contaminated with any bacteria around.
And I think that's the interesting thing we see with phage therapy is you really have different considerations that pop up because of the specificity. So it is, I know somebody, I just looked at some data from wound infections, and treating with a specific phage is difficult because there are always these second species that will pop up in a wound. Even if it's just commensals or colonizers, then you don't know how to deal with those. But the problem with prosthetic joints is the access and then the activity in serum or synovial fluid.
I've got to say, I'm glad you've said Staph aureus is the best or the easiest or whatever, because that's one of my pet bacteria. And the research group I work with have just got a grant actually to to run a randomized trial of phage therapy for patients with Staph aureus bacteremia that is persistent. So they're still blood culture positive after a few days. They'll get randomized to get a phage cocktail against Staph aureus or not.
Congratulations. That's great. That's what the field really needs, is more randomized trials.
So you talked about the easiest. What's the hardest, or what's an example of one that's really hard? Maybe
Go ahead,
Lawrence,
Lawrence.
you
You know
can
what I would.
take that
Yeah,
one.
Yeah,
Lawrence knows what I
I
would say.
always hear that Acinetobacter baumannii is supposed to be the hardest. For us in the lab, it's Klebsiella. We struggle a lot with Klebsiella because there are so many little things you have to evaluate. So for us, Klebsiella is definitely a challenge.
That's such a shame, because that's literally the bacterium that, breaks through all the antibiotic therapy, and that really, where we have the most hope for phage therapy.
I think only because it's hard for us, it does not mean that Klebsiella is not a good indication, because when you would have a broad library and all would be produced by after you have experienced how to do it, then it would still be a good option. But you would have to test always a lot of different bacteria against a lot of different phages to find the right phage.
And Shawna, what
I
do
think
you think about that?
I think Lawrence really explained that well, and it means that, Josh, with your indication of Staph aureus, it's easy from a product perspective, that you can have a few phages and have a cocktail ready that would treat a lot of your patients. Whereas Klebsiella is a super interesting indication, but it would be more individualized. It would be unlikely that you could have a cocktail. And this is also why in Georgia, they don't include Klebsiella as part of their cocktail composition. They do it as individualized treatments because of how specific they are. But if you have the right library, there are some wonderful researchers that have well-established banks of Klebsiella phages. And if you could then produce them in a reasonable time frame, I think actually Klebsiella could be a good target.
So, Lorenz, what to you right now is the best indication for phage therapy?
Oh, that's a good question. So I think if we take hard science, the actually only successful randomized controlled trial was on otitis externa. So from an evidence-based perspective, I would say it is otitis externa. However, there have been so many positive case reports and individualized cases presented. What do you think, Shawna?
I think that it is our evidence base right now is primarily based off of these case reports or small case series. And this has shown a lot of promise for patients. And I think that's why we see so much enthusiasm and support for phage therapy, which is really important to try to address the needs of patients that need phage therapy now. But one of the issues with them is that a lot of these cases are poorly documented. A lot of cases, both positive and negative, go unreported. So there's a real bias or lack of data completion about case reports. And one of the ways we're trying to address this is with an international patient registry called the Phagestry. And I have to say, this is a highly collaborative project that we've worked with so many institutions and leaders in the field to come about and create a phage-specific database and patient registry that'll be hosted through REDCap. This is really what we're trying to do now, we are in the setup phase of this project, and we're trying to onboard the different centers that are doing phage therapy treatments and collect all of the data of each of these case reports in a really standardized manner, and hope then to use this to create best protocols and also to support the future structure of well-designed clinical trials.
Great. Maybe we can hear a bit about a randomized trial you were involved with, or you led, Lawrence, a double-blind randomized trial testing intravesicular phage therapy, so into the bladder in patients with chronic UTI, which was compared against intravesicular placebo and antibiotic standard of care. So can you tell us what the trial found and what you think the results mean?
Yeah. So first of all, I think it was a little bit heroic of us, or we thought we are heroic to do that trial, and then we realized that it is actually not as simple as it seems to be, because all our Western world scientific evidence-based medicine really crashed with the empiric knowledge of the Georgian phage therapy. And it was not that easy to combine both, because they really know what they do and they do it very well, but their concepts are empirically established, and it is not that easy to bring that into a clinical trial afterwards. A lot of these things are not directly adaptable for clinical trials or for randomized controlled trials. And what we had to find, we had a study in mind that we want to conduct that in Switzerland, but we were not allowed to do that in Switzerland for several regulatory reasons. And then we thought, okay, we're going to try to do that trial in Georgia, and had fantastic partners who really worked hard in doing that trial. But it was from the hospital environment, it is much different than in Switzerland, where everything is strict, and where you have appointments for everything, and where you have to do clinical trial units, and everything is regulated. We had to do some compromises, and we were thinking that patients with catheters who anyhow have to be in a hospital are a good population, because they are in hospital. When they have a urinary tract infection, so you can treat them, and you will be able to follow them up. And this is how we came to the indication of urinary tract infections, or catheter-associated urinary tract infections, in patients undergoing prostate resection. What we did is we had these patients, they have undergone surgery, and when they had infection prior surgery, we said we give them either phages, antibiotic, or a placebo after surgery, to see if they have a clearance in bacteria, and to see if they have a clearance in symptoms or difference in symptom clearance. And on the same, what we did prior surgery is we took the urine, we let the urine grow, we looked were the bacteria we find sensitive to the phage cocktail we used. And what we found is that antibiotics and phages were equally effective to treat these, to find bacterial clearance and to find symptom resolution, but that phages were not superior to the placebo we gave. And I think two other striking findings, that sounds now rather exciting, but the striking findings were that antibiotics were actually super bad in bacterial clearance in infections. We only had symptom resolution and microbiological resolution in about not even 40%, it was at 34. And for phages, it was about 28, but even for placebo, it was about 30%. And then we realized that there are hardly any studies out there who show if there really is microbiological proof of therapy of antibiotics. And we saw that in general, the antibiotic clearance of infections is usually not higher than 60% for these conditions. And the other problem we had is that for the specific setting that we tested patients after surgery, symptom resolvent is probably not the best indication, because there are so many cofactors why these patients can have symptoms. They have a catheter in place, they had a surgery, and they can have pain just from the surgery itself. So after all, we learned a lot, and I think we had also the findings are interesting and important, but there are a lot of factors that can be improved and that we try to improve for future clinical trials.
And Lorenz, where was that published, in case people want to have a look?
It was in Lancet Infectious Diseases.
So I'm going to tell you guys something that I don't think you would have known. I was actually a reviewer of that paper, which was published because I really thought it was an excellent, just a beautifully designed and conducted study. For Western standards, for current methodologic standards, it checked all the boxes. It was, randomized, it was double blind, placebo-controlled. It was a lovely study. And yet, like you say, Lorenz, it almost felt like this was a clash of the West meeting the East. this Western understanding of how to approach antimicrobial therapy, sort of hitting kind of wall against this whole other world of phages and very individualized therapy. Normally, right, for phage therapy to be its most successful, it would have to be individualized, and of course you couldn't do that in this kind of setup. You had the cocktails. So now that it's been a few years, what, looking back, do you think you could have done anything differently? If so, what would you have done differently?
I give the word to Shawna.
I mean, we're going to try to do it differently, right? We're hoping to have our own trial here in Switzerland set up within the year. We discuss a lot of the things because that's it. Is now that we've had this experience, you would expect our next trial to be better. And I think the two things Lorenz and I discuss a lot is the appropriate choice of placebo, because there in that study, I mean, bladder washing isn't a conventional treatment for UTI. So is that a real
Interesting.
placebo, or is it also a treatment in itself? So I think finding an actual placebo that is a placebo is going to be difficult. It's something we discuss a lot. We haven't exactly decided what we will do, but I think that's one thing. The second thing would be to look at the appropriate primary outcome. So obviously, if you're treating a bacterial disease, you would, following Koch's postulate, expect that you would see a decrease of that bacteria in order to say that the patient is better. And especially with urinary tract infections, you can have the presence of bacteria, with asymptomatic bacteriuria, and not have symptoms. And so I think looking at microbiological outcome as a primary is also something we might not do in the future.
You would be very much in line with, current thinking, even for antibiotic therapy, of course, right? Because microbiologic outcomes, don't really matter to the patient. You can sterilize the urine all you want. If they're still having symptoms, they're not happy. And then sterilizing the urine is very temporary. You pick an early time point and you have a slam dunk. You have an easy study that shows everything you want. So I look forward. I hope. I don't know if I'm going to be a reviewer on your next one. That's for Lancet. I need to decide. I think now I probably can't. But I think I got a little intellectual conflict of interest there.
Lorenz, you had something to add?
Yeah, I think one important part we will change is we try to be less ambitious. We try to answer one question at a time, and we try to reduce the factors influencing the potential outcomes or the trial structure. So really, just for a monomicrobial infection, just for one pathogen, that we really can understand what was the effect. Because when we treated 5 different pathogens in that trial, this is a multiplicity of potential outcomes and potential confounders. So we really have to try to be less heroic and less ambitious to bring our knowledge forward. And this is probably also a statement that maybe more little results can also help when you really understand what you found.
Yeah, that's really interesting to learn from people that have done these trials, because they're difficult to do, right? Let's zoom out for a minute now and think about, I just want to ask you both what you think phage therapy will look like in 10 years from now. Will it still be a niche researchy thing, or is it going to be part of prime time? Shawna, do you want to answer that first?
It's a difficult question, because if you would have asked me that 10 years ago, I wouldn't have probably said, what we're experiencing today. So I think to answer it, it'd be good to reflect on the past 10 years. And we have seen some changes in terms of the ability to do or the frequency of these individualized treatment cases. Then I think in the next 10 years, we will see more clinical trials. This I do think we're going to see. I think we're also going to see some clinical trial failures. And I don't think we should necessarily be discouraged by that. So that's probably my hope for the next 10 years, is to have a lot more clinical data to work with. And like Lorenz mentioned, is to have realistic expectations. I think expecting phage to work as good as an antibiotic is highly unrealistic. It's about trying to find the value and to fit phage therapy into that process of, we tend to think of phages as a last resort treatment for patients that are failing every other option. And when we see a lot of success, it's actually when they're combined with antibiotics. So a lot of these individualized cases are combined with antibiotics, which is why we see such good results. But then we lose the microbiome sparing effect. We lose the lack of side effects. So there's a trade-off to that as well. And if we go back again to the Georgian experience with the over-the-counter products, is because they use them more as a first line to avoid more minor infections progressing. I think it'll take 10 years to see that paradigm shift. I still think we look too much for phages to save us from antibiotic resistance. I see it almost as well. We should be using them first in a more gentle approach than going straight to antibiotic use.
I should have asked about 20 or 30 years from now, probably.
Do you not worry that if we are sort of handing out phage cocktails, at the very beginning, so in a much more universal fashion, that we will end up with resistance to phages, just like we now find ourselves with antibiotic resistance?
I don't think it's as much of an issue. I mean, for two respects is first of all, resistance to phage usually comes at a cost to the bacteria. So the bacteria either becomes less virulent or less pathogenic. So sometimes phage resistance can be beneficial. Could be something, there are actually treatment strategies that look to use phages not as an antimicrobial, but to revert bacteria to antibiotic sensitivity. And then also, I mean, you don't see that in the countries that have been using phage therapy for so long. And this is primarily because the bacteria will evolve resistance. It's a for sure something we should anticipate, but also that you can then either change the phage because there's just so many of them. That'll be a limitation more on regulatory policy than it will be biologically. But you could change the phage, or also you can adapt the phage to the specific pathogen. So there's the ways of overcoming resistance to phages is easier to do from a biological perspective, but harder to do from a regulatory perspective. So in these 10 to 20 years, I also think the focus of the field collectively should be providing clinical evidence and then using that evidence to support why regulatory frameworks should be more flexible with phage therapy.
So in this 20, 30 years future, first line over the counter, do you think the counter will be that of a cocktail bar and the phage cocktails will come with a little umbrella in them? No, you don't have to answer that. That was a rhetorical question. And Lorenz, what about your thoughts on 10 to 20 years from now, place of phage therapy?
I'm very much in line with Shawna. I also think it will still stay a rather individualized therapy through the next year, probably through the next 1 or 2 decades, because our system just works differently. We need randomized controlled trials. We need phase 3 trials, which are expensive, which are difficult to do, and which are rather difficult to do with phages. I think we will get to the point where we also have most likely positive trials, but then it is always about the indication. For big pharma, it's not interesting to have individualized treatments unless the drug is a very good seller, where you get a lot of money. And for broad spectrum, you would probably need this cocktail solution, which is then again from the regulatory framework again more difficult to get approval for in our standards. So our aim is really to show them that it works, in what indication it can work, and then it is also our thinking of the treatment frameworks that they might change, that our treatment concepts might change, that we make a step up procedure where we first try potentially less effective therapy, and if they don't work, we go for more effective or for potentially more effective therapies. Like we start with phages, which have a potential benefit, and if they have a benefit, it's great. You don't need to go to stage 2. And afterwards, you would go to antibiotics. And I think if we can show that such a new treatment framework could work for infections, they are not at the beginning life-threatening, then it could be something for the broad, for everyone, for over the counter, that you have a UTI, you go to the pharmacy, you get your phage cocktail, you use it. If it did not work within 2 days, you start with antibiotics. Or you have a bad cough. Instead of going to your GP and he gets you antibiotic, you just try for the first 3 or 4 days phages, and if symptoms resolve, good. And if symptoms don't resolve, you still can go for the advanced options or for the other therapy. But till this change in our thinking of treatment concepts and changes, this will take more than 10 years. Till then, we have to get the evidence in individualized cases. This is probably the most likely scenario I have.
Okay, guys, so that was a really interesting exploration of phage therapy, and there's so much more to talk about. But here's your final chance. What are your take-home messages? Just a couple of key points from each of you. Lorenz, what are yours?
One key message from my side is right now and in the next few years, there is not the high time for phage therapy for broad phage application in patients, but it is actually high time for us, for physician scientists, for microbiologists, and also for general researchers, prove that these positive case reports can also show positive, or that we can prove that phage therapy really works also in patients on a better basis, and to find out what is the perfect indication for the therapy.
So we need more randomized trials, right?
Right. We need more randomized trials and we need better evidence. And this is our aim to bring that on.
Great. And Shawna, what are your key points?
I think I want to end with a message that I just want to make sure that it's clear, is that we're really dealing with an issue of unequal access to phage therapy right now. So I definitely support Lorenz that the priority in the field needs to be well-structured clinical trials. But at the same time, we've got the current need of patients, and this shouldn't be neglected. And there's only a growing but still a very small number of hospitals or institutions that can do phage therapy for individual patients, and it's limited in how that can be scaled. So right now, I just wanted to be clear to everyone, and if there be patients listening, that there are no approved phage therapy products for the treatment of bacterial infections in most of the Western world. So it's not something you can, go to your doctor and get a prescription for. It's really limited to if people can get in contact with physicians who are willing to put in the time, extra time and effort in organizing phage therapy, and then getting in contact with the centers that can produce the phages. But I think it's just difficult to scale phage therapy for the need of the patients now, but we need to keep the priority of strong evidence first and foremost.
Thank you so much, Lorenz and Shawna. Lorenz Leitner from Balgrist Hospital, Shawna McCallin, also from Balgrist Hospital in Zurich, Switzerland. Thanks to my co-host, Josh Davis from Newcastle, Australia. We could, I think, do a whole other hour on phage therapy. There are still so many questions that I think we all have. So I think you two have to come back. Thank you so much for being on. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Josh Davis and Angela Huttner, editors at CMI Comms, ESCMID's open access journal. It was produced by Angela Huttner and Dr. Monica Ballesteros, edited by Monica Ballesteros, and peer-reviewed by Dr. Olivia Funk of Long Island University. Theme music was composed and conducted by Joseph McDade. The executive producer of Communicable is Angela Huttner. You can subscribe to Communicable on Spotify, Apple, YouTube, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.